Now, I added this part because it's one of the, I think, starting to come up, even if it is still rare, ruptured uterus, or rupture of the uterus. But for us in this region, I think it is still a little bit common. It's one of the commonest also cause of antepartum hemorrhage. This just means that there is partial or complete tear of the gravid uterus. And I've tried to illustrate that there is a discontinuity of the uterine layers and some parts there, showing us that the uterus are ruptured. Yes, they don't go without risk factors. Risk factors are similar, however, previous operation on the uterus commonly predisposes these women to ruptured uterus. Among others include previous myomectomy procedure that was done, previous cesarean section, and in cases you have severe rupture of uterus due to corneoectopic pregnancy, we normally perform the procedure called wedge resection. And most of these mothers are also at risk of having rupture in the subsequent pregnancy. So we advise them to have an elective cesarean section planned for them. The other thing could be maneuvers on the uterus. Such maneuvers are done, but it's not actually acceptable nowadays. What we call the external cephalic eversion can also make these mothers at risk of having ruptured uterus. And also certain procedures like breech extraction. Also, we have manual removal of the placenta because when this placenta heals, it heals with scarring. And some of these scar tissues during labor time, this uterus will not be able to have capability of proper uterine contraction and relaxation, ending risking these mothers having what we call a ruptured uterus. Other risk factors are as I've actually indicated. Now, clinical features can be seen in two ways: when this mother is in labor or when this mother is not in labor. Now, while in labor, there could be this vaginal bleeding, there could be edema of the lower vagina and also vulva, what we call the cannula sign. There can be some retained placenta as well. And sometimes the uterine contraction normally stops or ceases following the hypertonic uterine contractions that occur initially, and then it can stop when the rupture now occurred. But we can continue to have this abdominal pain and also feature of shock. And it is important for us to appreciate shock is a common occurrence in these patients, which can be seen when the patient is very less restless. We have sweating, profuse sweating, even have hypotension, and also sometimes the patient may be tachycardic. Of course, we have other clinical features like hypovolemia and even deformity, and sometimes the fetal heart sounds are irregular or may be absent, indicating that the fetus has died. Now, what about when this mother is in labor? These clinical features are common. Sometimes they have had trauma to the abdomen, blunt abdominal trauma, risk these patients getting their ruptured uterus. Previous operation, as I said before, and when you examine these mothers, they're difficult to palpate the abdomen. And these mothers continue to have vaginal bleeding that is actually profound but may not be proportional to the level of shock that they have, because the bleeding, normally they bleed intra-abdominally, and so blood tends to collect within the abdomen. And if you to look at what is coming out through the vagina, then it may not be easy for you to indicate that, yes, this patient is actually in typical shock because of blood that you are seeing out. Now, management of ruptured uterus, just resuscitate these mothers. Resuscitate at all times. Of course, don't forget to call the team for help, because we need very many stakeholders in the clinical practice to help this mother. We need the anesthesia team, we need the midwifery team, we need the nursing team, the doctors to come and help, and also people around to help us to move things like in waste segregation and all that around. So we need everybody when we are managing this patient. So teamwork is the one I call for. However, as they're calling for help and for teamwork, make sure you set up IV line, large bore cannulas, preferably 2 large bore cannulas, to resuscitate this mother, while you are giving them crystalloids, which can be normal saline or even Ringer's lactate. And administer IV tranexamic acid if you have in your setting. I know soon the government will start providing us with tranexamic acid. It will be requested for in the normal requisition cycles. Refer this patient if you are in lower facilities, you are in health center 3, refer them where they can perform operation, they can perform hysterectomy. So refer them. But if you are able to access these garments, what we call the non-pneumonic anti-shock garment, it will help you to minimize complication as you're transporting your patient to the CMOC facility. The CMOC facility is supposed to be able to have these 9 signal functions, including blood transfusion and cesarean section, but also to perform cesarean hysterectomy. Now, give oxygen to these mothers and transfuse them. Ideally, it may be of little significance. However, you take the patient to theater, clamp the bleeder, and start the blood transfusion when you achieve, you have already achieved hemostasis, and then that blood transfusion benefit is to the maximum. Catheterize the bladder to make sure there is continuous bladder drainage, and also provide parenteral antibiotics. This patient are at risk of having infections, so make sure you provide them with broad-spectrum antibiotics, as I've given there. But one more last thing that I want to say is not the last, but it's not also the first. It is among the package that is to do is perform laparotomy as immediate as possible. Now, this is what I have been talking about, the algorithm for management of ruptured uterus. Diagnosis of the ruptured uterus is made. You check if the patient is in shock. If the patient is not in shock, what do? Then you still prepare this patient and go to theater. If the patient is not in shock, still make sure you prepare this patient, resuscitate, and take the patient to theater. Theater, we perform laparotomy, and then if you are not in the facility which does that, then you have to refer them. That's why I say refer to CMOC facility. Then make sure that some rupture of the uterus can be repaired, others cannot be repaired. Those that can be repaired could be having a uterine scar dehiscence, or the desires for these mothers to have more children is there. So you try to salvage the uterus so that you can still repair, so that the mother can still carry pregnancies. However, if you cannot repair because of excessive rupture of the uterus, what do? You do hysterectomy. And here you can, depending on the skill of the clinician, you can either do hysterectomy type 1A or type 1B. 1A being supracervical hysterectomy, where you remove only the body of the uterus, you leave the cervix. Or you can do total abdominal hysterectomy, where you remove both the cervix and the body of the uterus. And therefore, this confirms to us the scenario that we have had in the beginning of the presentation. This is a typical case of antepartum hemorrhage. It is now upon us to make sure that we make a diagnosis where the cause is commonly, the cause could be abruptio placenta, because this patient has had blunt abdominal trauma. If it was because of placenta previa, probably this patient start bleeding spontaneously without significant trauma. Yes, so more to light on this is diagnosis is antepartum hemorrhage due to placenta, abruptio placenta. Thank you very much. I want you to go forth and serve with love and honor. Thank you.